Good morning, ladies and gentlemen. So when Habib asked me for a keynote lecture, I thought uh, one thing that I have always felt personally is that I feel ashamed to present the same lecture second time. So it needs to constantly change. For me, if I'm presenting the same lecture next year, that means I'm stagnated. I don't have anything new. So that's where I would be discussing mostly what we did in the last 6 months, something that is new. Last 6 months happens to be the last 6 months of 2019. So I'll be talking on those things. There have been many things that has happened, but I will speak only on 3 things. I get royalties from Springer for these 2 textbooks. My research is partly funded by the von Humboldt Foundation in Germany, and I received professorship grants from the Friedrich Alexander University again in Germany. So these are the 3 things that I would be speaking upon. So let's begin. Balloon dacryoplasty. Now if you look at the evolution of balloon dacryoplasty in the last decade, at present 2 major companies produce it. And on an average, you get 1 balloon set for approximately $300 US. But I practice in India. $300 US is a big amount of money for a lot of people. Right? For somebody, for a child, it's not easy. So I was thinking, why not do something where I can get this cost down, right? And then I had an exposure to the coronary angioplasties. You know, coronary angioplasties, they do left, right, and center, so many of them. So one of the angioplasty procedures that I was observing, I found that they used 4 balloons for different areas because they needed different diameter ones. And that led me to think that can I use this coronary angioplasty balloon for a balloon dacryoplasty. I'll probably just give you a video of this one. This is an Indian-made coronary balloon dacryoplasty. The only difference is that it's a little long because, you know, coronaries, they usually go through the femoral and then they go to the coronary arteries. But that really does not matter much. And there you see, it's a little long than the traditional balloons. Another advantage that we have for coronary is that you get it from less than 1 millimeters to up to 30 millimeter diameter. Whereas the traditional balloons dacryoplasty, you get is for 2 millimeter and 3 millimeter, right? But who said 2 millimeter and 3 millimeter? Who decided 2 and 3 millimeters? It's just arbitrary. We never go back and question the people who have built 2 millimeters and 3 millimeters. Well, there's no evidence 2 millimeters or 3 millimeters. So I thought, let's go and explore this area. There you see, the other thing that it has is guide wires, because you need guide wires when you're going into coronary arteries and minor vessels. So you just pull a little bit inside. You don't use it that much as they use for coronary angioplasty. And then subsequently, you realize that it's pretty easy. That's the balloon and that's the inflation device. You use it as a lower lock mechanisms. And there, it's ready. And that's for building up the pressure. I'll just take you to another bit of it, just to show you the coronary balloon. It's just a little long video. I don't want to waste a lot of time in that one. The only thing that I want you to understand is that something can be done using coronary balloons. This is the inferior turbinate. I'm coming into with the balloon there, and you go ahead and dilate all the similar protocols of balloon dacryoplasty that you can do. I won't go into this video. But what is important to understand is that when we looked at the Lacricath, the Optacath, and the coronary balloons, we assessed not only the feasibility of doing it, but we assessed a lot of physical parameters, like for example, the insertion profile, the rate bursted pressure, the inflation device features, and we found that it's actually the coronary does much better on many parameters than the traditional balloons. And look at that cost, $350 versus $90. You have cut down almost to 1/3 of the cost. And if you repeat, you know, like the inflation device, you can reuse it again and again. The inflation device is mostly given up. You can use an ETO and you can reuse it, but most of the time in the West, they use a new one, which I don't feel is economically feasible, and it doesn't matter if you reuse the inflation device. So that comes down to $60 actually. So in $60 today, we should be able to do a complete balloon dichroplasty procedure using a new balloon. So the significance of that is that you have reduced the cost of that one. So that is also another responsibility that falls on us. While imaging, while a lot of new techniques come in, we should be very conscious about the people we are addressing. So this is just published, and you can, it's a detailed paper, you can have a look at that. The second definition is about the Horner's muscle. Another thing that has plagued medicine for a long time is we don't question what has been put up in the literature 30, 40, 50 years. If somebody says it's Horner's muscle or muscle of Riolan, we continue believing that that's how the anatomy is there. My belief is that the anatomy and physiology of every structure of the body needs to be revisited every 2 to 3 decades, because there's so many new techniques by which you can reassess those things. So that's why we looked at the anatomy of the Horner's muscle, and this is one of my fresh frozen dissection that you can see there. You see the common, this is lacrimal sac, this is the common canaliculus, and this is the beautiful canaliculi that you see, including the punctum and how beautiful the vertical canaliculus and horizontal canaliculus are. So what we did was that we took histological sections of at every 500 microns. So we wanted a very, very good histological sections through the entire length from the punctum right up to the sac. So we had thousands of sections. And those thousands of histological sections, like you see over here, those thousands of histological sections, we asked the computer to reconstruct it. So we wanted a histological anatomy of the structures rather than what we see. And you see how beautifully the computer reconstructs all that histology, taking all those sections one after another. Okay, and then once we did that, we also wanted to look at the scanning electron microscopy of this area. And we went ahead, this is a cross-section of the canaliculus that you see, very beautiful arrangement of the muscle around it. And then we went ahead and we, see, to know the exact orientation of the muscle, we need to section it at all possible angles. This is a longitudinal section where you see, this is the canalicular lumen, and this is the muscle that's around that period. This is a cross-section that I showed you yesterday, where you see this beautiful bundles of Horner's muscle. But what was interesting was that this is the canalicular lumen, and this was a connective tissue. Hell a lot of connective tissue to which this muscle was attached, right? And if I take you a little more closer, you'll be able to understand. Look at that, this is the lumen of the canaliculus, this is the connective tissue, and see how beautifully the muscle is interacting with the canaliculi. Further high magnification of that. Just to show you how deeply the connective tissue is there within the muscles as well. Once we did that, we sent these whatever data we had to something called as pattern recognition laboratories. And that's where they reconstructed the whole thing. This is what you see in the red is the muscle. A little bit gray that you see is the connective tissue. That means there's a lot of connective tissue around. And there you also see on that board, if I can show you, this is the punctum, right? And you see that the muscle is actually coming right up to the punctum. So the concept that there was a muscle of Riolan was an error. We did not find any muscle of Riolan. So we have put up in the literature now that we should stop using that term muscle of Riolan, because there was no muscle of Riolan, and it's actually the muscle of Horner's that comes right up to the punctum and has a very typical architecture here. Again, if you can see there, so you can keep cutting it as you like, in any way you like. You see that one? How beautiful the canaliculus actually traverses between the muscle over here. Then once you do that, we wanted to look at how this muscle is very different from others, or is it just same like any other skeletal muscle of the body. So we did something called as enzyme assays, where we looked at succinate dehydrogenase to classify what kind of fibers are there, whether they are type 1 fibers or type 2 fibers. I know it looks a little boring, but what is very important for all of you to understand is that if we really want to progress medicine, you might be a fantastic surgeon. You might be doing great balloon dichroplasties, but your ability to assess those fibers should also be equally good. So that combination of a fantastic surgeon and a fantastic scientist is a very lethal combination for advancing medicine. And that's what I would advise the youngsters in the audience to pursue. So we look at this succinyl dehydrogenase, and what we found very typical that this Horner's muscle is not like other skeletal muscles where there's a predominance of it. There was almost equal predominance of type 1 and type 2 fibers, which means there's a fast fibers, acting fibers, and slow acting fibers. And this is one of those samples from the masseter, which we took as an example, where you see one type of fiber predominating. We assessed the diameters of each of these muscle bundles and found that it to vary not as much as this one. It was a very fine fiber arrangement as compared to other skeletal muscles. Once we did that, we wanted to look at the neural innervation. We know that Horner's has a facial innervation, facial nerves, but is there something else beyond that? That's when we did a lot of immune histochemistry studies to assess for tyrosine hydroxylase, which you see in the green, which is a marker of autonomic sympathetic neurons, right? So this muscle has very good sympathetic innervation as compared to other skeletal muscles. And FACT, which is vesicular acetylcholine transferase enzyme, the one that you see in the green one, here, subjects, that means that there's a lot of parasympathetic innervation also within the muscles. We did a lot of other things like calcitonin, reactin proteins, and many other things. So what does it mean? That there is not only a good sensory and motor innervation, there's a good amount of autonomic innervation within this muscle. Right? And to make sense of all this data, then we reconstructed it to make it simplify how it is. So today, the way we understand Horner's muscle is that it is right from the punctum till 2/3 of the horizontal canaliculus. And then it leaves the canaliculus, the medial most portion of the canaliculus, and it goes back and attaches behind the lacrimal sac. But while it is attaching behind the lacrimal sac, it gives part fibers to the posterior part of the lacrimal sac. So what does it mean? Right, this is another arrangement, very different arrangement in the canalicular area. So what does it mean? It means that it is actually 360 degrees opening the canaliculus like this and contracting it, if you look at it in a cross-sectional way. But if you look at it in a horizontal section, what happens? So whenever we blink, it's a very simple thing, right? When I was growing up, it was so difficult to understand how this muscle and how this drainage system is happening because it looks so complex, but it's pretty simple. When we are closing the eye, this portion, wherever the Horner's muscle is, it's constricted completely. The canaliculus is constricted. And the remaining portion dilates. Simple. And when you open it up, so what happens once you constrict and this dilates, there's a negative pressure here which sucks in the fluid. Also, because the canaliculus is compressed, it pushes the fluid into this area. And once we open the eyelids, this gets dilated and this gets compressed. So what would happen? The fluid from this portion would be propelled inferiorly into the nasal cavity. Very simple. Now, once that was there, we did not want to publish this new data of Horner's because there was a fundamental historical error that has happened in 1822 when William Edmund Horner, who was one of the anatomists in the United States, actually wrote a letter to a guy called John Shaw at Moorfields Hospital. And on 6th April 1822, John Shaw placed that letter into a journal at that time, which was called as London Medical Repository. And he said that this is a new muscle that needs to be described. But it was actually, when we digged up the literature, it was actually French guys who long back in 1735, there was a guy called Charles Schaubinger. His thesis actually showed his mentor, who was Francois-Marie Duvernay, who had actually described it the first time, and we had good evidence of that one. So we said, let's correct a historical error, and let's rename this muscle as Horner's Duvernay muscle in recognition of the contribution of Duvernay, who had done that much before what Horner had done. Right? So that's where this is now accepted. So for publication, so subsequently, when we put up this literature, we'll call it as Horner's Duvernay muscle and not pure Horner's muscle. The third and the last, sealing the etiopathogenesis of dacrylolithiasis. Why do I call it sealing? Because way back in 2018, we actually did electron microscopic, both scanning and transmission electron microscopic analysis of this lacrimal sac concretions or lacrimal sac, what people commonly call as dacrylolithiasis, which is again a wrong term. So the correct term is mucopeptide concretion whenever we find that. So like I was showing you yesterday, this particular picture, we found that the core of that is actually made out of a lot of fibrin and blood products. And that was universal. So that made us think, is it that the blood acts as a nidus around which there is a lot of mucopeptide depositions, and that's what becomes the dacrylith? And that's where we went ahead and did a lot of immunohistochemical analysis of those concretions, and we found that yes, in fact, it was the blood products and fibrin, von Willebrand factors that were at the core of the dacrylith. And once that happened, we wanted, this is all about the core of the dacrylith, immunohistochemical things. So we thought, let's go and do a cinematic rendering. So what we do normally today with imaging techniques is that we get 3D volume rendering technique. Whenever we see 3D CTs or 3D MRIs, they are volume rendered. But today we have techniques where we can do something called a cinematic rendering. What does cinematic rendering means? It means, for example, if somebody shows you this CT image, right? And if the computer can give you this image of the same from the radiology, how different is this, isn't it? How accurately you can assess what is happening over there. That's the power of cinematic rendering. And if from a simple thing like this, if the computer can reconstruct all these things for you, look at the way you look at anatomy. It's totally different, isn't it? So that's where we wanted to do something. And you see my picture, I'm a little stunned because the first time I saw 7 Tesla MRI, and we wanted to cut this tissues, these dacryliths, these concretions that we had, we wanted to cut it much smaller because the concretions are very tiny. And if I want to image the concretions, which is like 1 or 2 millimeters, I need some imaging that cuts at 50 microns, 70 microns. And that's where 7 Tesla we used. And we did a lot of things. So this is how the dacrylith looks like. What you see here is the tube actually, and this is the dacrylith. And we wanted to image that one. Look, what do we see? So I'm cutting the dacrylith now, one after another. So what do you see here? It still remains the same if you go back and look at this one. So you see a little small something in the center of that one, right? And if you cut it up more, there you see it more clearly, which is very different in consistency and density from the rest of the dacrylith. And that was favoring, again, that hypothesis that we had that blood was acting as a nidus. And if you look at this one, another example of a dacrylith, this is another one. There you see in the center that's acting like a nidus. So then we assigned different density to different portions of the dacrylith. And what we found that most of it, there are 1 or 2 areas where it can act as a nidus. There you see one beautiful areas of nidus. And then we enhanced it to assess those nidus areas where we cut it and wanted to assess the structural thing. And there you see another portion of the nidus. So what happens, today we know that because of any physical trauma or chemical trauma, in predisposed individuals, within the lacrimal sac, there is epithelial breach because of any reason. Whenever there's an epithelial breach, there's a small amount of blood that leaks. Once that blood comes, the lacrimal sac has a tendency to bridge that epithelial breach like it happens in the stomach by placing a lot of mucopeptides in that area. So there are a lot of mucopeptides that come to bridge that gap. Secondarily, there's a lot of mucopeptide secretion that starts happening in the tears, and the tears again flow through the lacrimal sac. So mucopeptide over mucopeptide around the nidus starts forming up. And that's how dacrylithiasis happens. It took us 3 papers to come to that. But now that etiopathogenesis is completely sealed up. We are now working on canalicular concretions and how different they are. So these are the people with whom I learned a lot, and they are somebody whom I would always be thankful for teaching me a lot of these cinematic rendering techniques, and Siemens for coming up with such innovative things. So I hope I have entertained you. Thank you so much.